Hello and welcome everyone to the CanCOVID speaker series. I'm so excited to have you all joining us today. We are joined by Dr. Jonathan Irish. Thank you so much for being here, and his deck has it quite dense and it is full of wonderful information, so that it will be posted on CanCOVID on the Slack after his presentation. So if you miss anything, don't worry, you'll be able to find it again. Thank you so much, and take it away, Dr. Irish.
Great. Thanks again for the opportunity of presenting this work. And for the purposes of this presentation, as already mentioned, it's pretty dense. So I'm going to concentrate on the effects that COVID-19 has had on surgical services, but you can extrapolate this to other services, procedures, medical care, imaging, and so on in the whole healthcare system. So it really demonstrates the impact that COVID-19 has had on our healthcare system, has had on our patients, and most importantly, the challenges for recovery that we face as we emerge from the apex of the pandemic, and in Ontario as we've entered the second wave. One of the issues that I just want to outline is we had a bit of a technical issue, so I'm going to have to use the old-fashioned next slide, please, which I apologize for. Next slide, please. So have you advanced? There we go. So this discussion is based on the paper that's published in the Canadian Medical Association Journal. And again, I want to recognize and thank the incredible expertise of all of the authors that are listed here, and many of whom, of course, know much more about modeling than I do. But I'm going to emphasize the significance of the modeling and its results from a clinical perspective and from a patient perspective. I'm also going to provide some updated information as we move forward, and of course this was published based on data and modeling from mid-June. And if you go on to the next slide, this slide really describes the COVID-19 timeline in the province of Ontario and outlines some of the critical waypoints of COVID-19. But really for us today, it really is about the time when the Chief Medical Officer of Health directed to reduce or discontinue elective and non-emergent procedures in order to create capacity for patients with COVID-19, which resulted in a precipitous decrease in all surgical procedures in the province. And until May 26, when he directed that a slow ramp up of surgeries and elective surgery can occur on that date. And in fact, our paper describes the backlog accumulation that occurred during this time and carries it forward until June 13th. And as I've already mentioned, I'll be presenting updated data which shows the continued backlog accumulation that has occurred even after June 13th. Next slide, please. And this is the impact, and these graphs really show quite vividly the impact of the reduction in surgical services. In the background, you can see that the black or gray lines show the historical volumes of activity that were performed in 2017, 2018, and 2019 for comparative purposes, and in fact, on which our model is based. You can see that the significant drop of 38% in cancer surgery, vascular surgery 73%, and of course all the way down to benign surgery where there was a 96% drop in clinical activity. And the impact of care, of course, is the gap between historical volumes. After all, COVID-19 didn't cure cancer, it didn't cure cardiac disease, nor did it solve all of the chronic problems that patients have and require surgical correction for, like hip joint replacement and cataract surgery. Next slide. And the next slide actually talks about not only the activity reduction that occurred in March, April, and May, which were at the apices of the pandemic, but even after directing to recontinue or reopen surgical volumes, you can see the reduction in surgical activity that has occurred in June, July, and August in comparison to our historical numbers. And I'll talk a bit more about why that has occurred. It has a lot to do with screening, which shut down completely. It has a lot to do with diagnostic services like CT and MRI scan. And it has a lot to do with patients not seeking medical care with the primary care physicians and specialists. Next slide, please. And this is the background and methods of our paper. The province of Ontario has had one of the most robust wait time information systems since 2005. It actually was a result of SARS. We divide surgical procedures into 4 priority levels in cancer, cardiac, and in benign disease. And priority level 1, which is life or limb, are not included in this discussion today. It really is about the so-called elective surgery, which is priority level 2, priority level 3, and priority level 4. And each one of those priority levels has maximum time targets associated with them. The service reduction is a backlog size for the P2 to P4 surgeries were estimated as the difference between the expected, which is the 2017 to 2019 historical volumes, to the observed service volumes that we saw between March 15th and June 13th. And the backlog time was then estimated by dividing the backlog size by the throughput of the operating room using regional and provincial data, so-called inputs. And then we assumed a surge of 1 day per week using 50% of the operating rooms available for an 8-hour period, which is about a 10% increase in volumes, just to demonstrate what it would take to clear the backlogs for administrators, surgeons, and surgical leaders. Next slide, please. And the project purpose was to inform regions, to inform surgeons, to inform hospitals, to inform stakeholders about the expected size of the backlog and what it would need to clear the backlog in the 6 service areas that we looked at: cancer, cardiac, vascular, transplants, pediatric surgery, and benign surgery. Basically, procedures that require a fully equipped operating room, and to clear the backlog in weeks, and the resources in the form of OR hours, the number of ward and ICU beds. And in fact, we also modeled PPE requirements. Next slide, please. And this is the slide that really describes the model framework. Now, let me explain. There are basically 3 colors of boxes. There's an input box, there's a process box, and finally there's an output box. And each of these boxes has different colors and can be modified according to hospital, region, or provincial data. In other words, it can be customized. On the left-hand square, you can see that this is really describing the backlog size. And on the right-hand square is the time to clear the backlog and the resources that are required. And this can be modified again by hospital data, regional data, or provincial data, and can become customized to numbers that are inputted. The key input parameters for us included operating room time, ward and ICU length of stay, the estimates of the number of operating rooms, and the historical proportions of surgeries requiring ward and ICU utilization. As far as process goes, you can see on the left-hand slide, it's the incremental backlog size accumulation, and I've already described how that was estimated. And on the left-hand slide, the left-hand side, the process was the backlog that was processed per week, given the surge capacity available. And the surge capacity that I will discuss today will be that 10% increase in resources. So that 1 day per week running 50% of the ORs for 8 hours a day, which is approximately a 10% increase in resources. And the output, which is shown in the far right-hand bottom, which is the weekly OR time required, the ward and ICU bed requirements, and the time to clear surgery, based on all of the data that we've inputted. Next slide. A little less heavy. So here, some of this, some of the assumptions that we made. The surge capacity will start once regions reach 100% of their expected volumes. Volumes and backlog will continue to accumulate. This is important to understand. Our backlog will continue to accumulate until we hit the 100% historical volume. And we won't reduce the volume until we exceed that. Another assumption was that there was no prioritization of patients. In other words, all patients were treated alike. Now, in fact, we went on to model time urgent operations, cancer, cardiac, and high priority vascular surgery, and I'll discuss the results of that if we just prioritize those patients alone, again, ahead of all others. The other assumption was that we did not assume any cap on weekly ward or ICU bed availability. Again, utopia. And some of the other assumptions are shown there. Next slide. With regards to backlog, we forecasted the expected number of surgeries using time series forecasting models by region and by surgery type. The forecasts, as I've already mentioned, were based on historical weekly data from January 2017 to October 2019, and we validated them on data from October 2019 to March 8th, 2020, prior to the shutdown. The results reflect a gradual recovery of surgical activity based on real-world data, and I'll talk a bit more about that shortly. The completed volumes per week are based on the observed data up to June 13th, and this is important to understand. We assume that on June 13th, all of a sudden that hospitals went to 100% of their historical volumes, and at that point we're surging above that to reduce the backlog. And again, I will show you that that was not the case, and so the backlog in our paper is now greater than we reported, because in fact we know now, it's now October, we know that surgical services did not exceed the 100% historical volumes and surge appropriately. If you go on to the next slide, this is the provincial input data. Again, a relatively heavy slide. You can see the data sources across the top and the accumulated backlog in cancer surgery, vascular surgery, cardiac surgery, and benign surgery based on the numbers shown. You can see just over 5,000 cancer operations in the backlog, of which 1,500, just over 1,500 were priority level 2 or priority level 3. And of course, just over 128,000 benign surgical procedures that needed to be cleared in the backlog. You can see the OR time required, and this can be modified to hospital or regional level, the percentage that required ward utilization or ICU utilization, ward length of stay, ICU length of stay, and finally the number of ORs that would be available to clear the resource. Next slide. So I'm going to share the results based on the input data that I've presented, and if you go on to the next slide, you'll see that this is the backlog that was accumulated. The mean surgical backlog was 148,000 patients for each week. For each additional week of the shutdown, we do about 11,400 surgical operations. a week in the province of Ontario, just over 650,000 a year. You can see by the graph that the majority of the backlog is accounted for by benign surgery. The cardiac cancer surgery accounted for 3.5% of the backlog, and pediatric surgery 8.3% of the backlog. And together, vascular surgery, cardiac surgery, and transplant surgery accounted for less than 2% of the backlog. Next slide. This is the backlog type by region, so by type of surgery and by region. And you can see we can divide it into regional data, as well as, in fact, we can go to the hospital level. And you can see in just over 5,000 cancer operations, 128,000 benign surgeries, and 12,000 pediatric operations. The output is in the following slide. Next slide, please. And it shows, using this data, you can see that both at the provincial level and by regions, you can see the, obviously, as I already mentioned, the backlog size and the time to complete or estimated clearance time to clear the backlog. In Ontario, it would take 84 weeks to clear the backlog of surgery in 148,000 patients. And you can see that across that line, which is outlined in yellow, you can see that there is variation from region to region in the ability to clear the backlog because of the differences in OR times and the complexity of the surgery, as well as the backlog number and the type of patient in the backlog. So for example, you can see that 120 weeks to clear in Toronto versus the 74 weeks to clear in the central region in the province of Ontario. You can also see that the estimated resources required, in addition to weeks or time, the number of ORs required per week to clear the backlog, the ward beds per week, and the ICU beds required per week. And these are all incremental on top of baseline. So you can appreciate the enormity and challenge that we would be faced with to clear that backlog. Next slide, please. So for all surgery site types, even with a 10% surge activity, it would take 84 weeks to clear the backlog. We also, by the way, and I mentioned this earlier, I did a model just for time-sensitive surgeries. In other words, we just prioritized cancer, cardiac, and transplant surgery, and it would take 14 weeks to clear the backlog, assuming that all surgery resources are dedicated to time-sensitive surgeries only. And I've already mentioned the number of weekly resources in operating room hours, ward beds, and intensive care unit beds that would be required in other resources to clear the backlog. Next slide, please. This slide shows that, in fact, on June 14th, that did not happen. As you can see, this is the percentage of volumes that continued after June, July, and August and up to September 30th. And you can see that, again, as long as we're below the 100% historical number, we are not clearing the backlog. And in fact, the backlog continues to accumulate. So in fact, the estimated COVID-19 related surgical backlog is now 185,000 patients and will continue to accumulate until we reach the 100% and will not reduce until we surge past the 100% historical volume rate. The next slide. And this is the cancer surgery only. And you'll recall that I mentioned we had in our model somewhere around 5,500 cancer patients in the surgical backlog, and that is now over 7,000 patients. As we continue, you can see the surgical volume activity as of September 20th for cancer surgery. And in the background of all this, as we go to the next slide, you can appreciate that there is a further tsunami after the earthquake effect, because there are patients that are held up in the diagnostic pipeline. You can see that patients are waiting or in the, there is a backlog of CT scan activity in staging and in other non-staging for cancer or non-cancer CT scans. You can see the reduction of breast cancer screening and MRI scanning, and you can see that in general, the diagnostic resources reduction where patients are in a sense still in the pipeline who may not yet have even been diagnosed and require surgery, biopsy, or other surgical interventions to care for their condition. And just to further emphasize that, if you go to the next slide, here is the screening activity, colonoscopy, screening for colon cancer. You can see the dramatic reductions in screening activity in colonoscopy, cervical cytology and colposcopy, mammography for breast cancer, and finally high-risk patients with low-dose CT scan lung cancer screening. So you can see that when the services open up as they are now for screening, you can appreciate the second wave, not of the virus, but of patients coming through the diagnostic pipeline, which will be a further challenge with regards to caring for our patients moving forward. If you go to the next slide. So the key takeaways, obviously, is we have an enormous backlog in the province of Ontario, but it's not unique to the province of Ontario. This is, in fact, a worldwide problem. And the clearance times are almost numbing with regards to the clearing of the backlog, assuming the modeling activity. And even if we apply and prioritize patients to time-sensitive surgeries alone, the enormity of our task is not insignificant. But we have developed an adaptable tool that can be adapted to jurisdiction, hospital, region, and province throughout this country and other countries as well to really model the resources required to obtain clearance of backlogs that have occurred during COVID-19. And if you go to the next slide. So I want to thank you for the opportunity. I'm sure this has raised lots of questions and thoughts regarding next steps. I would say that there are probably two areas where we'd probably want to emphasize. This is reactive, meaning solving a problem that has accumulated as we shut down activities during the course of the pandemic. But there's also a proactive opportunity here where for future waves, we can look at novel or innovative ways to somehow maintain services that are critical for patients without necessarily closing them down in a broad way. And we can talk more about that, as I'm sure there will be questions raised about how we can avoid this for future waves. But again, I want to thank you for the opportunity and open to questions.
Absolutely. Please feel free, everyone, to put your questions in the chat box and I will read them aloud, or you can turn your monitor on and go ahead and ask. And I see Vivek's monitor already on. Go for it.
Right. Great, thanks. This is fascinating and really important work. I guess one question is, I think I saw one of the assumptions was mortality, people that die on the waiting list are attrition. What about people whose condition progresses to the point where surgery is no longer indicated? Presumably that happens with some cancer patients as well.
Yeah, so in our, I can speak from Cancer Care Ontario's perspective. So yes, we assumed and applied a 10% attrition rate secondary to mortality statistics, not just from dying from disease, but dying of other causes. There's also, Vivek, as you can imagine, issues around surgery appropriateness in the case of benign surgery. There's also the opportunity in many conditions where we can consider alternate options of treatment. For example, neoadjuvant chemotherapy in some cancers, or in a multidisciplinary cancer clinic. I know in my cancer clinic, for example, we were using options of maintaining or using radiation treatment instead of surgery. where it was obviously appropriate for the condition. So, you know, I think there's many examples where the attrition may in fact be higher or lower. At least in cancer, I know that we, in our multidisciplinary cancer groups, attempted to mitigate some of the effects of surgical resource reduction by using some of the tools that were available to us.
Yeah. And then I guess the related point is, as you're looking at, and I guess this gets to the prioritization, and maybe it's more of an ethics question. How do you deal with, if you have new patients coming in who are still at an early stage, could benefit from a more immediate surgery, but then you've got someone who's been waiting a long time? How are those types of prioritization decisions being made?
Yeah, so great question. And, you know, one of the things, and I guess I didn't completely answer your first question, number one, in that a lot of time surgeons spent during the apices of the shutdown was in monitoring patients' progression during the course of the slowdown. We slowed down, you know, around 38% in cancer surgery services, and we were constantly upgrading patients or up prioritizing them where possible. And in fact, I'm lucky, I work in a group of 6 head and neck surgeons entirely dedicated to head and neck surgical oncology. So we would essentially meet every twice a week, in fact, to basically prioritize the next patient, whoever's patient it was, into the next available slot. And I think that mitigated to some extent, and a lot of major centers and cancer surgeons did that moving forward as well. What was the second part of your question there?
I think that gets at it. So it's like, if I think about like a new patient being diagnosed with breast cancer, who's got, you know, immediate surgery may be quite beneficial, but then you've got someone who's been waiting for 3 months.
Yeah.
How do you weigh the ethics of that?
Well, probably that's a huge question and important, but we did come up with a prioritization at Cancer Care Ontario, and I know other agencies in cardiac and so on. We came up with prioritization sort of advice on how to prioritize patients. The scale, there were many scales developed, University of Chicago and other groups developed prioritization scales of how to prioritize patients for surgery or treatment. Let's take surgery out of it for that matter. The lucky thing for us is a lot of the decisions were not made by a surgeon, but were made by a group. And it really took a lot of the onus and pressure off us, because I have to say it would have been very much more difficult making those judgments just as sitting here as a single surgeon with, let's say, a group of patients to care for. So we spent a lot of time discussing this as a group and prioritizing based on all of the qualities and, you know, curability, quality of life, what impact would delay have with regards to critical structure and survival. And these were tough discussions to have. And it's not unlike the tough discussions that other jurisdictions have had, for example, in Northern Italy, where they had to make prioritization decisions regarding who gets a ventilator. And it's not dissimilar. And these were tough discussions to have.
Thank you.
Thank you for that. This has been fantastic. We're at 4:30. So I want to thank you for your time and for sharing this fascinating statistics with us. And thank you everyone for joining us. And we'll see you at the next speaker series next Tuesday.